Assalamu alaikum wa rahmatullah. Good evening, everyone. My name is Dr. Khaled Elsayad. I am a radiation oncologist at Munster University Hospital, specializing in cutaneous lymphoma radiotherapy. I will give you today a summary about cutaneous lymphoma radiation indications, and I have no conflict of interest. This is my outline. I'm gonna start with radiotherapy indications. Then I will speak about radiotherapy, modern radiation doses, and technical considerations. As you know, according to WHO EORTC classification, T-cell lymphoma represents 70% of cases, and cutaneous B-cell lymphoma, such as marginal zone follicular center lymphoma and diffuse large B-cell lymphoma, represents about 30% of cases. I will start with mycosis fungoides, which have a very characteristic immunohistological and clinical manifestations. Mycosis fungoides represents 50% of cutaneous T-cell lymphoma with median age of 60 years old. Clinical course patients represents with patches, plaques, or tumor manifestations. In patients with leukemic form, we will call this disease form Sézary syndrome. Patients with early stages have a very long survival, more than 10 years, and patients with nodal or visceral manifestations will have shorter survival. Based on our ILROG, International Lymphoma Radiation Oncology Group, we recommend a dose between 24 and 30 gray in patients with solitary lesions. However, in patients with multiple manifestations will require lower doses with 1 time 8 gray or 2 fractions 4 gray up to 3 fractions with a very similar complete remission rate, more than 90%. As a radiation oncologist, you have to irradiate the lesion plus 1 to 2 centimeter safety margin, and please don't forget the deep margins. So you can use 6 to 9 or 12 mega electron volt electrons with or without bolus, or in sometimes you may require photon irradiation. In patients with multiple lesions, you can irradiate tumorous lesions with 1 time 8 gray or 2 fractions with 4 gray. And you can reach a very high complete remission rate, more than 90% in cases. I have 2 examples from my department. Here, patient with 2 tumorous lesions, we applied 2 times 4 gray, and within few days, patients get complete remission of those lesions. Another example, 1 time 4 gray, and 1 week later, patients had complete response of these lesions. In literature, you find a lot of studies from Munster University Hospital. I will give you a brief summary about the most common indication for total skin electron beam. Patients with more than 10% of body surface area can receive total skin electron beam. Standard low dose is 10 to 12 gray in 8 to 10 fractions. However, during Corona pandemic, we applied another concept or another radiation regime with 2 fractions of 4 gray with a very interesting and encouraging results. The most common irradiation technique for total skin is the Stanford technique. Here you see the patient should stand in 6 different positions. Radiation session will take about 10 to 15 minutes. And during irradiation, patients should wear eye shields and nail protections to avoid toxicities. According to dosimeter measurement, you can apply additional local radiotherapy to underdosed areas such as perineum and plantar surface, or tumorous lesions or enlarged lymph nodes. We know that a conventional radiation dose with 30 gray is very effective treatment with a complete remission reaching 90% in cases of mycosis fungoides, but severe side effects and high recurrence rate was a barrier between radiation oncologists and dermatologists. So in the last few years, we started with the low-dose total skin electron beam regimes. Here you see that the overall remission rate with 10 to 12 gray reaching 80 to 90%. However, the complete remission rate was significantly lower. But with such a regime, we have a very interesting advantages such as minimal adverse events and better tolerability on the quality of life. And the treatment duration ranging from 2 to 3 weeks with possibility of repetition. Total skin electron beam in patients with large cell transformation, which was CD30 positive cells before and 8 weeks after treatment. This patient showed complete response. Besides the significant improvement in cutaneous manifestations, we also observed improvement in quality of life using different instruments such as dermatological life quality index, which was significant improve up to 24 months after irradiation. In another instrument, Skindex 29, we also showed significant improvement of patients' quality of life up to 9 months. And in subdomain analysis of FACT-G instrument, we also showed significant improvements in symptoms, emotional functioning subscales. In the current national and international guidelines, after radiotherapy, we should apply maintenance treatment with one of those agents according to EORTC guidelines to prolong the clinical improvement as long as possible. I will move now towards the primary cutaneous anaplastic large cell lymphoma, also immunohistological characteristics, CD30 positive T cells and ALK1 negative. Most of cases are males. Most of patients have solitary lesions. Extracutaneous spread is very rare in this entity, and the treatment of choice of localized diseases is surgery or radiotherapy. According to the LROC study, you can apply low radiation doses with 6 gray up to 45 gray. In subgroups analysis, we showed a similar response rate and complete response rate with 30 or less than 30 gray, and with our higher doses, up to 45 gray. The overall response rate was 100%, complete response rate was 97%, and there was a very low in-field relapses even with low doses. So according to LROC guidelines, you can apply 24 to 30 gray. Some examples from different clinics. This patient treated with 30 gray. Afterwards, she had complete response. Also with 20 gray, patients from MD Anderson, 4 months this patient had complete response. And even with ultra low doses with 6 gray, the patient showed complete response. The next entity is cutaneous B-cell lymphoma. CD20 positive cells, most of cases have indolent course, such as follicle center or marginal zone lymphomas, and the more aggressive form is diffuse large B-cell lymphoma. The usual treatments for localized lesions, indolent B-cell lymphoma, are surgery or radiotherapy. However, patients with diffuse large B-cell lymphoma will receive combined modality with immunochemotherapy plus radiotherapy. Concerning indolent cutaneous B-cell lymphoma, you will find a lot of studies with conventional radiation doses, and recently lower radiation doses with 2x2 gray showed also a very encouraging results. So according to the International Lymphoma Radiation Oncology Group guidelines, you should apply 24 to 30 gray, also with 1 to 1.5 centimeter safety margin. According to tumor types, you can choose your electron energy. More complex sites or localizations can be treated with photon therapies. And very interesting, you can also achieve complete response in patients treated with 2x2 gray with a median time to relapse up to 10 months. One example for follicular central lymphoma after 2x2 gray complete response, and marginal zone lymphoma treated with 2x2 gray showed also complete response. As T-cell lymphoma, you can also repeat this radiation doses more than 10 times if required. And you can also have the chance to escalate the radiation dose up to 24 gray. In patients with diffuse large B-cell lymphoma, you should apply immunochemotherapy as a first treatment, plus or minus with or without radiotherapy. And please don't forget the pre-chemo GTV distribution. And also, please don't forget the deep margins. One example for patients treated with 36 gray after immunochemotherapy using a photon therapy tomotherapy machine. The patient showed complete response 6 months after radiotherapy. In conclusion, radiotherapy is a very effective treatment for patients with cutaneous B-cell and T-cell lymphomas with a very good quality of life after treatment. Combined modalities seems to be associated with clinical benefit in patients with advanced mycosis fungoides and patients with diffuse large B-cell lymphoma. Further studies are required, and please, you should cooperate with your dermatologist, oncologist to reach the best treatment regime for your patient. I would like to thank my colleagues in cutaneous lymphoma work group at University Hospital of Münster for their efforts and time, and thank you for your attention.